Good morning everyone. Today we will study oxygen transport. At the end of this lecture, you will learn what are the various modes of oxygen transport in various forms, how it is transported in various forms. So, coming to modes of oxygen transport. Oxygen is transported from lungs to tissues by two methods: physically dissolved in the plasma and in combination with hemoglobin in the red cells. So mainly it is transported, that is approximately 98% of oxygen is transported in combination with hemoglobin and the remaining 2% in the physically dissolved form. In the physically dissolved form in plasma, only about 2% of oxygen is transported. The amount of physically dissolved oxygen in the blood can be predicted from Henry's law. Henry's law is what? It states that amount of gas that dissolves in a liquid at a given temperature, it is proportional to the partial pressure of the gas. Thus, the quantity of dissolved oxygen in arterial blood can be calculated from the following equation. Dissolved oxygen is equal to oxygen solubility multiplied by partial pressure of oxygen in arterial blood. So, oxygen solubility is 0.003 ml per deciliter of blood per mmHg multiplied by 95, that is the partial pressure of oxygen in arterial blood. So, it comes out to be 0.3 ml per deciliter of blood. Thus, at a arterial pressure of 95 millimeter of mercury, the dissolved oxygen is 0.3 milliliter per deciliter. That means in a normal healthy adult, 0.3 ml of oxygen is transported in dissolved form in 100 ml of blood. As cardiac output is 5 liter per minute at rest, so oxygen is transported in dissolved form at rest is about 15 ml per minute. So oxygen transported in dissolved form alone is grossly inadequate to meet the oxygen requirement of the body, which is about 250 ml per minute at rest. In combination with hemoglobin, how much it is transported? So we will see that more than 98% of oxygen it is transported in combination with hemoglobin. So this becomes possible due to binding affinity of hemoglobin for oxygen. Hemoglobin that binds with oxygen is called oxyhemoglobin, and hemoglobin that does not bind with oxygen is called deoxyhemoglobin or reduced hemoglobin. So how oxyhemoglobin is formed? The hemoglobin molecule, it is a protein made up of 4 subunits that are bound together. Each subunit consists of a molecular group known as heme and a polypeptide attached to the heme. The 4 polypeptides of a hemoglobin molecule are commonly known as globin. Each heme group contains one atom of iron to which oxygen binds. So you can see the structure of hemoglobin molecule. Globin chain, ferrous. So please see this iron is in ferrous form, not in the ferric form, and there are 4 pyrrole rings at each end. Since each iron can bind one molecule of oxygen, a single hemoglobin molecule can bind 4 molecules of oxygen. Hemoglobin binds with oxygen only when iron is in ferrous form. You have already seen that iron is in ferrous form. The ferrous iron is in hemoglobin, it is oxidized to ferric iron to form methemoglobin. So thus methemoglobin cannot bind oxygen. Methemoglobin formation occurs under the influence of various compounds like nitrites or sulfonamides. Methemoglobin is also formed spontaneously, but there is an enzyme in the body, that is methemoglobin reductase, that is present in the red cells, that reduces methemoglobin to hemoglobin. So normally about 1% of total hemoglobin is methemoglobin. So normally this is present in the blood, but this is being reduced by the enzyme methemoglobin reductase. So if there is deficiency of methemoglobin reductase in the blood, so it will increase the methemoglobin concentration and there will be decreased oxygen carrying capacity in the blood. Oxygen binds rapidly and reversibly to hemoglobin to form oxyhemoglobin. What are the What are the various states of hemoglobin? Let's see. During the process of oxyhemoglobin formation, heme remains in the ferrous state. This process is oxygenation, not oxidation. As there are 4 subunits in hemoglobin molecule, hemoglobin reacts very rapidly in less than 0.01 second with 4 molecules of oxygen to form oxyhemoglobin, HbO8. When oxygen is not bound with hemoglobin, that is deoxyhemoglobin, 4 subunits of hemoglobin, these are tightly bound with each other. This configuration of hemoglobin is called tense state. In this configuration, affinity of hemoglobin is less. So now what will happen when the oxygen will bind? When first molecule of oxygen binds with hemoglobin, 4 subunits enter into the relaxed state that exposes more oxygen binding sites. So in our configuration, affinity of hemoglobin for oxygen is greatly increased by 200 to 500 times. This is very important point to remember these R and T states. So when PO2 is very less, most of hemoglobin molecules are in T state and have low oxygen affinity. When PO2 is very high, the hemoglobin molecules are in R state and have high oxygen affinity. Thus, the quantity of oxyhemoglobin formation, that is oxyhemoglobin that is formed, it is a function of partial pressure of oxygen in the blood. In pulmonary capillaries, what happens is when as there is high PO2, the reaction favors to form more oxyhemoglobin, and in tissue capillaries, because of metabolism, carbon dioxide is high and PO2 is low, the reaction will favor the formation of deoxyhemoglobin. So this process will favor oxygen to be deloaded from hemoglobin and it will become available to the cells. So this is known as Bohr's effect, that will be explained later on in detail. Now what is oxygen carrying capacity of hemoglobin? Each gram of hemoglobin binds with 1.34 ml of oxygen. The maximum amount of oxygen that can be carried by hemoglobin is called the oxygen carrying capacity. In a healthy individual, oxygen carrying capacity of arterial blood is around 20 ml of oxygen per 100 ml of blood. So as we have taken that hemoglobin concentration is 15 gram %. So 15 multiplied by 1.34 ml is equal to 20 ml roughly oxygen per deciliter of blood. So now coming to oxygen content of hemoglobin, it is the amount of oxygen actually bound to hemoglobin, whereas oxygen capacity of hemoglobin is the amount of oxygen that can potentially bind with the hemoglobin. Now coming to percentage saturation of hemoglobin, with oxygen it is a ratio of the quantity of oxygen actually bound to the quantity that can be potentially bound multiplied by 100. Now coming to very important oxygen hemoglobin dissociation curve. Oxygen hemoglobin dissociation curve or equilibrium curve, it explains the relationship between the partial pressure of oxygen in blood with oxygen saturation of hemoglobin. You will draw PO2 on the x-axis, on the horizontal axis, and oxygen saturation on the vertical axis, y-axis. So this curve is an S-shaped curve, sigmoid curve, over the range of PO2 from 0 to 100 mmHg. So this sigmoid shape results from varying affinity of the hemoglobin for oxygen at various PO2 levels, because affinity is not same for at each PO2, it varies. As PO2 rises, hemoglobin saturation progressively increases. However, the saturation is not linear with increase in PO2, for which the curve becomes sigmoid shaped. So what is the importance of this S-shaped hemoglobin equilibrium curve? It enables oxygen to saturate hemoglobin under high partial pressure in the lungs and to give up large amount of oxygen with small changes in the PO2 at the tissue level. So this is the curve. You can see range from PO2 0 to 100 and percentage saturation of hemoglobin from 0 to 100. You can see this curve is sigmoid shape. This is very important point to remember. And the steep part you can see, and this is the plateau part above 70 mmHg. Now curve is as you have seen that curve is divided into two phases, steep phase and plateau phase. Steep phase, the curve has a steep slope between PO2 of 10 and 60 mmHg. During this phase of the curve, combination of oxygen with hemoglobin increases very rapidly as the PO2 increases from 10 to 60. So oxygen saturation in the steep phase is about 90% at PO2 60 mmHg. What is the significance of this phase? Oxygen saturation is very high. Less increase in PO2 leads to great percentage saturation of Hb and oxygen loading. Also change in steep portion of the curve in reverse direction. That is, when you go from 60 to 10, it will cause unloading of oxygen in the tissues. Small decrease in PO2 in the tissue results in unloading of large amounts of oxygen into the tissues. That means there will be very less change in PO2, but tissues will get enough oxygen for their needs. So steep phase allows large quantities of oxygen to be released from hemoglobin in the tissue capillaries where a lower capillary PO2 prevails. So this is achieved by shifting the curve to right. So in the tissues, what will happen? Because of high PO2, curve will shift to the right by increased H ions and by increased CO2. Now coming to plateau phase. Plateau phase begins at around 60 mmHg, flattens at PO2 70 mmHg. The increase in PO2 above 60 mmHg produces only a small increase in oxygen binding. Increase in PO2 from 60 to 100 mmHg in the plateau region of the curve illustrates that oxygen saturation and content remain apparently constant over a wide alteration in alveolar period. Now coming to significance of plateau phase. So there are two significances of plateau phase in different situations, like when we go at high altitude or if the person is suffering from pulmonary diseases in which a moderate hypoxia occurs. The total amount of oxygen carried by hemoglobin decreases only by 5 to 10%. Since hemoglobin saturation is about 90% at PO2 60 mmHg. So in the curve, this curve, plateau phase, provides a safety factor. That means if suppose there is decrease in lung function, mild decrease in lung function, it can, even then it can allow normal saturation of hemoglobin. Oxygen saturation and content remain fairly constant in spite of wide fluctuations in alveolar PO2. For example, if PaO2 rises from 100 to 120, hemoglobin saturation increases only slightly from 97 to 98. This is the reason why oxygen content cannot be raised appreciably by hyperventilation or by breathing 100% oxygen, because hemoglobin is already completely saturated with oxygen at PO2 of 100 mmHg. This is true only for normal people at sea level. If a person has low arterial PO2 due to lung disease or his ascent to high altitude, hyperventilation or breathing 100% oxygen increases hemoglobin saturation with oxygen. Now what is P50? It is the level of PO2 at which 50% of hemoglobin is saturated with oxygen. P50 assesses the binding affinity of hemoglobin for oxygen. In adults at sea level, normal P50 occurs at PO2 of 27 mmHg. Alteration in the P50 value has a greater impact on steep phase of the curve. If the P50 is high, it signifies the decrease in affinity of hemoglobin for oxygen, which is seen in right shift of the oxygen hemoglobin equilibrium curve. If P50 is low, it signifies shift of curve to left, in which the affinity of oxygen for hemoglobin is more. You can see this graph, effect of P50 on oxyhemoglobin dissociation curve. Factors affecting hemoglobin binding affinity with oxygen. Now there are many factors which influence the affinity of hemoglobin for oxygen. The important factors are temperature, arterial PCO2, arterial pH and 2,3-DPG. Now if there is a rise in PCO2, that is there is hypercapnia, and fall in pH, that is there is acidosis, or rise in temperature as occurs in the tissues. All these factors occurs in at the tissue level. Rise in PCO2, fall in pH and rise in temperature curve will shift to the oxyhemoglobin dissociation will shift to the right. And this is known as Bohr's effect. What is Bohr's effect? The effect of carbon dioxide and hydrogen ions on the affinity of hemoglobin for oxygen is known as Bohr's effect. This is a phenomena that is seen at the tissue level. So shift of oxyhemoglobin equilibrium curve to the right is physiologically advantageous at the tissue level, as the affinity of oxygen for hemoglobin is lowered and oxygen gets deloaded from hemoglobin and tissues get enough supply for their needs. So rightward shift enhances the unloading of oxygen for a given PO2 in the tissues. And if there is left shift, for example, there is decrease in temperature, decreased carbon dioxide, so there will be increased affinity of hemoglobin for oxygen, so lowering the ability to release oxygen to the tissues. Simple way to remember the functional importance of this shift is that an exercising muscle is warm and acidic and produces large amounts of carbon dioxide, all of which favor the unloading of more oxygen to the metabolic active muscles. So as in exercising muscle, temperature will increase, there will be more carbon dioxide production, more HIs. So all these factors will cause unloading of oxygen from the hemoglobin, so that tissues need more oxygen and tissues will get more oxygen by shifting the curve to the right. Increase in temperature will cause the shift of the curve to the right, and if there is decrease in temperature, curve will shift to the left. In other words, you can say that high temperature decreases the affinity of hemoglobin for oxygen. This helps in the release of oxygen in metabolically active tissues in which temperature is more. Now you can see the effect of temperature on the oxyhemoglobin dissociation curve. This is the normal curve at 37 degrees centigrade. In red lines are the these are showing the effect of increased temperature on oxyhemoglobin dissociation curve. You can see shift to the right, and if there is decrease in temperature, you can see curves shift to the left. Now coming to the effect of pH on the curve. If there is acidosis, respiratory acidosis, curve will shift to the right. So a decrease in pH shifts the curve to the right, and increase in pH shifts the curve to the left. So what will happen when blood passes through the capillaries? So carbon dioxide will enter the blood cells, so pH will decrease and oxyhemoglobin curve will shift to the right. It has been noted that under normal physiological conditions, binding of about 0.7 mole of HIs causes hemoglobin to release 1 mole of oxygen. So when blood passes through tissue capillaries, the acidic environment will cause the release of oxygen from the hemoglobin. Now you can see in this curve that if there is decrease in pH, that there is acidic pH, curve will shift to the right. You can see the blue line, that is the normal, and left side is the alkaline pH. Curve has shifted to the left from the center. Now coming to the effect of carbon dioxide, as we have already discussed that increase in carbon dioxide concentration will shift the curve to right. The shift to right in acidosis is due to effect of decrease in pH and due to direct effect of carbon dioxide on hemoglobin. What happens is carbon dioxide combines with the amino groups on hemoglobin to form carbamino groups. The formation of carbamino group causes negative shift in the charge on the one amino acid side chain that changes the conformation of hemoglobin. So this will result in decreased affinity of hemoglobin for oxygen. Now in metabolically active tissues, metabolic vasodilation increases blood flow to tissues, increasing the oxygen transport to the area. Now what is the effect of 2,3-DPG? 2,3-DPG, what is 2,3-DPG? Red cells lack mitochondria. Anaerobic glycolysis occurs in red cells. So during glycolysis, a compound is formed. Large quantities of 2,3-DPG, diphosphoglyceride, an organic phosphate compound, is produced as the intermediate metabolic pathway. This compound is called 2,3-biphosphoglyceride. So this is much higher in red cells than in other cells. This significantly affects the affinity of hemoglobin for oxygen. In red cells, concentration of 2,3-DPG is almost same as that of hemoglobin. So 2,3-DPG binds to hemoglobin in 1:1 ratio, interacting with a central cavity formed by two beta chains. 2,3-DPG has about 3.5 negative charges that interact with the 8 positive chains. So this will destabilize the interaction of hemoglobin with oxygen. So binding of 2,3-DPG with hemoglobin shifts the oxyhemoglobin dissociation curve to right and facilitates the release of oxygen. At the tissue level, increase in 2,3-DPG facilitates unloading of oxygen from the red cells. Hypoxia stimulates glycolysis, resulting in increased production of 2,3-DPG. Red cell 2,3-DPG increases in anemia, exercise and hypoxic conditions like high altitude, chronic lung diseases, etc. So in these conditions, oxyhemoglobin dissociation will shift to the right. Now, what are the factors that will affect the concentration of 2,3-DPG in red cells? First is pH. Acidosis will inhibit the red cell glycolysis, so there will be decreased 2,3-DPG concentration in the red cells. And type of hemoglobin. Gamma chains of fetal hemoglobin have less avidity for 2,3-DPG than the beta chains of adult. So fetal hemoglobin has a higher oxygen affinity. So this provides advantage to fetus, so that more oxygen can be extracted from the maternal blood. Fetal hemoglobin shifts the dissociation curve to the left. Hormones like growth hormone, thyroxine and testosterone stimulate the synthesis of 2,3-DPG. At high altitude, more 2,3-DPG is formed. So this increases the availability of the oxygen to the tissues. Hypoxia increases 2,3-DPG concentration. But if the blood is stored in blood bank for many days, 2,3-DPG concentration will decrease. So transfusion of stored blood will decrease the oxygen transport, especially when transfused into hypoxic patients. Myoglobin is the hemoglobin pigment in the muscle. It is similar to HB in structure. Myoglobin binds one molecule of oxygen per mole. So it shifts oxyhemoglobin dissociation curve to left and becomes curve is not sigmoid. Here curve is hyperbolic. So this helps in picking up of oxygen from blood. Myoglobin is more in regularly exercising muscles, especially in the those who are trained in isometric exercises. This helps the muscles to draw oxygen from myoglobin, especially when blood flow ceases for a long duration during sustained muscle contraction. Myoglobin is also believed to facilitate transfer of oxygen from blood to mitochondria. You can see a curve. One is the curve, normal curve you can see. Then you can see fetal hemoglobin has shifted the curve to the left side, and in myoglobin curve it is a parabolic curve. Then carbon monoxide shifts the dissociation curve to the left, which releases oxygen release to the tissues. So severe tissue hypoxia occurs in carbon monoxide poisoning, which is fatal if not treated immediately. Normally in healthy individuals, carbon monoxide occupies 1 to 2% of the hemoglobin binding sites. But in chronic smokers, traffic personnel, etc., those who are exposed to smoke continuously, carbon monoxide concentration increases, and it can occupy 10% of hemoglobin. So we have seen that what are the factors that shift the curve to the right. So this is increased temperature, decreased pH, increased PCO2, increased 2,3-DPG, hypoxia, shift factors that shift the curve to the left: decreased temperature, increased pH, then if there is decrease in PCO2, decrease in 2,3-DPG, fetal hemoglobin and carbon monoxide. Coming to oxygen delivery to tissues, the diffusion of oxygen from capillaries to tissue fluids. When the arterial blood reaches the peripheral tissues, diffusion of oxygen occurs from the peripheral blood. This occurs along the concentration gradient of oxygen from area of higher level to lower level. The PO2 in the systemic capillary blood is 95, whereas in the interstitial fluid it is around 40 mmHg. So there is a greater pressure gradient due to which there is large pressure difference between the systemic capillary blood and tissue fluid that causes oxygen to diffuse from the capillary blood into the tissue fluid. So PO2 falls rapidly into the capillaries to about 40 mmHg. So PO2 blood of the blood that leaves the capillaries and entering the systemic veins, it is around 40 mmHg. From tissue fluid, oxygen will rapidly enter the cells. In the intercellular fluid, PO2 is about 23 mmHg, as oxygen is being constantly utilized by cells. Especially in metabolically active tissues, gradient is more as mitochondrial oxygen utilization is more. You can see a diffusion of delivery of oxygen from capillary blood to tissues due to the pressure gradient. There are pressure difference. Because of pressure gradient. In the arterial blood it is 95 mmHg, in the venous blood it is 40 mmHg, and in the tissues it is 23. So there is diffusion of oxygen from the arterial blood to the tissues. Bohr effect. Any factor that shifts the oxyhemoglobin dissociation curve to the right decreases affinity of oxygen for hemoglobin. At the tissue level, carbon dioxide enters the blood and shifts the curve to right. So this will help in unloading of oxygen from hemoglobin, and it will facilitate tissue oxygenation. This phenomenon is called Bohr effect, as it was described initially by Christian Bohr. This occurs mainly due to decreased pH in the tissues. Increased temperature of the blood in the tissue also contributes. In tissues, acidification of blood decreases affinity of oxygen to hemoglobin. As deoxygenated hemoglobin binds H more actively than that of oxyhemoglobin. Importance of oxygen saturation and content. Oxygen saturation is the ratio of amount of oxygen bound to hemoglobin to the maximum amount of oxygen that can bind hemoglobin. 100% oxygen capacity. At 100% oxygen capacity, heme groups of hemoglobin are fully saturated with oxygen. Oxygen content. Oxygen content of blood is the volume of oxygen contained in unit volume of blood, which includes oxygen bound to hemoglobin and also dissolved in plasma. Oxygen extraction is the amount of oxygen taken up by the tissues from the blood. So this is an index of oxygen consumption of the tissues. It is better quantified in terms of oxygen extraction ratio. Oxygen extraction ratio is also known as oxygen coefficient ratio. It is the amount of oxygen extracted by the tissue divided by amount of oxygen delivered. So these are the references. Now what we have learned, that oxygen is transported in combination with hemoglobin and dissolved in plasma, and it can be depicted in the form of oxyhemoglobin dissociation curve. Then this curve can be shifted to right or left depending upon the needs of the body. Thank you.